Good morning and welcome to Health Matters with the Medicine Center Pharmacy. I'm your pharmacist, Paul White. We're glad you joined us today. Before we begin, I'd like to thank our sponsors, Aultman Health System, Studio Arts and Glass, and Genuor Appraisals and Liquidations. I'm joined by Brad White, compounding pharmacist and our Vice President of Operations. Today, Brad and I are broadcasting from our administrative offices, and our special guests are Dr. Sabrina Shield. Did I have that correct? Please correct me. Okay. Sorry. Of Aultman Breast Surgery, and Dr. Sareena Singh of Aultman Gynecologic Oncology. Good morning and welcome to the show.
Morning.
Morning. Thank you so much for having us.
Cancer is a word used to define a collection of diseases that share one unique characteristic: the uncontrolled growth of cells that have the potential to spread or metastasize to other parts of the body. Gynecologic cancers grow from reproductive organs, including the cervix, uterus, ovaries, fallopian tubes, vagina, and vulva. In 2020, breast cancer surpassed lung cancer as the most common type of cancer diagnosed in women, and cervical cancer is currently the second most common gynecological cancer. This morning, we're going to talk with Dr. Shalad and Dr. Singh about both preventing and treating cancers, as well as exciting news they have to share about the new opening of the Aultman Cancer Center. We'd like to remind our listeners today, our program can also be found on our podcast. You can download it from the App Store using your favorite podcast app. Just look for Health Matters with the Medicine Center Pharmacy, and please subscribe to our program.
So, Dr. Shalad, welcome to the show again. We're happy to have you this morning. Please tell our listeners a little bit about yourself and your background.
Great. Thank you. It's been a very exciting week here at Aultman. So I'm a breast surgical oncologist. I'm the current medical director of the cancer program, as well as the director of the breast program here at the hospital. So I did general surgery training, and then I did a breast surgical oncology fellowship at the Cleveland Clinic. And so that's sort of been my background in training. I've been at Aultman since 2010. I originally did general surgery and trauma, and then I sort of transitioned over to taking care of women with breast cancer and some men as well. And so that's sort of been my transition. And then when I transitioned, I did extra training in breast surgical oncology to sort of focus in, and I used to have a little bit more training and expertise on breast cancer.
So why did you specialize in breast surgery?
Honestly, I think it was the women. I mean, it's this amazing group of women who are just sort of doing everything they're supposed to, and then they get hit with this cancer diagnosis. It's a very, breast cancer doesn't care who you are, what you do, any of those things. And it's just women who are sort of doing everything that they're supposed to. It's a very amazing group of patients. And then we do have some men who get breast cancer. And so it's the same with that population. I mean, they're just normal, average people of usually average risk, and they have this diagnosis, and it's a nice patient population to work with. I mean, I love my patients. It's nice to be able to take care of just such great people.
Is there a difference between breast cancer in men and women?
So women can have different types of breast cancer. Men usually just have one type of breast cancer, usually just ductal cancer, but the treatment is essentially the same, and outcomes are actually the same as well. So stage for stage, men do just as well with breast cancer as women do.
Interesting. So what kind of training required for you to become a specialist in this area?
So I did 5 years of general surgery training, and then I did 1 year of breast surgical oncology training. And then along with that is just continual updates, CMEs, national conferences, in being the most up to date as I can be to take care of people who have breast cancer.
So besides breast cancer, what other types of breast conditions can you treat?
So we treat any benign breast diseases as well. So sometimes those are women who have chronic breast abscesses. Sometimes it's non-cancerous lumps and bumps that are causing problems. Sometimes it's women with nipple discharge. Now, we always think about nipple discharge as a warning sign of breast cancer, but there are other non-cancerous reasons that women have breast cancer, and it's something that we work on and evaluate as well. One of the other things we actually see a lot of is actually breast pain. Women have breast pain. Most women will tell you that at one point or another, their breasts hurt. And it's something that we sort of go over different things they can do. some conservative things they can do to help manage that breast pain that they have.
Can that be related to size, breast size?
It can be, but not always. I mean, along with that, so one of the first things we always tell women, some of our bigger breasted women, is make sure you have good bra support. Make sure you're wearing a bra that fits you well and is very supporting.
Okay, so once someone is diagnosed with breast cancer, what types of treatments are available?
So it's a multidisciplinary approach. So there's a bunch of doctors who work together as part of a team. So we have surgical treatments. And so surgical treatments usually involve either a lumpectomy or a mastectomy. So removing part of the breast or removing the whole breast. And then for women who choose either option, sometimes we work with a plastic surgeon to help reconstruct the breast shape and mount. So that way the breast looks more aesthetically normal when we're done. We want women to have good looking breasts. A lot of women do great with breast cancer long term. And so we want them to, live long, happy, healthy lives. And when they get out of the shower and they look in the mirror, they're happy with the way things look.
Wow.
There's medical oncologists. So medical oncologists work with anti-endocrine therapy, chemotherapy. And so they're part of our team as well. We have radiation oncologists who sometimes do radiation treatments to the breast and the chest wall. And we also have our radiologists as well as our pathologists. So we all sort of work together to help take care of these women with all these different modalities.
Dr. Singh, we're not ignoring you. So here we go. Please introduce yourself and to our audience and tell us a little bit about yourself and what you do.
Sure. Good morning, Dr. Sareena Singh with Aultman Gynecologic Oncology. So as was mentioned before, my specialty is in treating precancerous and cancerous conditions of the female genital tract. So all of the organs that Brad listed before. Part of my job is spent as being a surgical oncologist, and the other part of my job is spent in giving patients other cancer-directed therapies such as chemotherapy, immunotherapy, and hormonal therapies. And similar to Dr. Shalad, not just limited to cancerous conditions of the female pelvis. We do a lot of complex surgery for non-cancerous issues and otherwise simple procedures that may become complicated by patients who have high-risk medical issues or high-risk past surgical history.
So what made you decide to specialize in gynecologic I can't talk this morning. I've said these words a million times. Okay. Oncology, go.
So my specialty is a specialty that comes out of general OBGYN residency. So my first decision was deciding, what my initial general training was going to be in. And I picked OBGYN because similar to Dr. Shalad, I was very passionate about women's health. And the unique aspects about that specialty are that you establish and maintain sometimes lifelong relationships with your patients from the time they're first seeing their gynecologist and needing a birth control pill to the time of birth to the time of menopausal issues. And then from there, my interest grew more into the cancer field, mostly because it's a little bit more surgically driven. And I also really like the multidisciplinary approach to our treatments. As Dr. Shalad said, we're every day working with other doctors, other surgeons, medical oncologists, radiation therapists, and I like the team-based approach and also still maintaining that lifelong relationship with a woman and seeing her through some tough times.
What sort of training do you need for your specialty? I mean, this has to be very involved, I would think.
Yes. So everybody starts out going through their OBGYN residency, which is 4 years. And then particularly for me, I did 2 fellowships. My first fellowship was in advanced female pelvic surgery. That was 1 year long. And then I did my specific GYN oncology fellowship, which depending on the program is anywhere from 3 to 4 years. Mine was 3 years, 1 full year of which was dedicated to basic science research in the lab and 2 years of clinical. Basically, it ends up the 2 years of clinical training split up into learning our advanced surgical techniques and also learning chemotherapy. So after medical school, I did a total of 8 years of postgraduate training.
All right. Dr. Shalad, let's talk about what types of surgery you perform in the treatment of breast cancer.
So we have, I guess, those 2 main options. So one is lumpectomy, which is where we just remove part of the breast. And the other is mastectomy, where we remove the entire breast. Now, when we do a lumpectomy, one of the things that I like to do is I move around the breast tissue and then I sew it back up so that way women don't have divots or funny looking breasts when we're done. So that really helps the natural shape and contour of the breast. Sometimes if we have to remove more tissue, we like to work with our plastic surgeon. And they can actually come in and essentially do a reduction or a lift at the time of women's lumpectomy surgery. I like to tell women that for women who are bigger breasted, they've always sort of considered or been interested in a reduction. I mean, going through cancer is tough. And so I tell them that this is one of the few silver linings I can give them is that, if you've always wanted a reduction, this is your chance and we can take care of it all at the same time. Now, when we do mastectomies, traditionally, no reconstruction and we can make women as flat as they want to be. Now, a lot of times we're doing reconstruction with a plastic surgeon. Now, one of the things that I am able to do is preserve the nipple in the areolar complex, and it's called a nipple-sparing mastectomy or nipple-saving mastectomy. So what we do is we preserve the entire skin envelope, and then we can use that skin envelope, work with the plastic surgeon, and that way women have a more natural-looking breast. One of the things that's been newer that our plastic surgeon and I have been doing, which is pretty fascinating. So usually when we talk about nipple-sparing mastectomies, it used to be smaller breasted women. So women who are traditionally an A, B, or a C cup. One of the things that we've been doing more recently is that women who are bigger breasted, our plastic surgeon is working in new ways to still do nipple-sparing mastectomies. And so lots of credit to our plastic surgeon who's able to do these newer techniques and bring those newer techniques down here to our patients in Stark County. So it's been exciting to be able to work with him and have him do all these cutting edge technology on women when otherwise we wouldn't be able to save nipples. And so it's exciting for us.
Okay, our first break is here, doctors. You're listening to Health Matters with the Medicine Center Pharmacy. Welcome back to Health Matters with the Medicine Center Pharmacy. Did you know we offer free prescription delivery? Call your Medicine Center Pharmacy to learn about prescription delivery program. Okay.
Dr. Singh, can you talk about, besides gynecological cancers, what other conditions do you treat?
So I treat precancerous conditions. So I see a lot of patients with cervical dysplasia or vulvar dysplasia. I treat a lot of patients with advanced endometriosis and pelvic pain, and also enlarged fibroid uterus. Or like I said before, just, procedures that otherwise would be technically not so challenging, but are challenging due to patients' other conditions. Maybe they're morbidly obese, maybe they have COPD and have don't have great lung function, require oxygen, and so their perioperative care becomes a little bit more complicated. So it's a wide variety of precancerous, non-cancerous, and cancerous conditions that we treat surgically, and also medically we treat menopausal symptoms, skin changes such as lichen sclerosis or lichen planus. So it's always something different all day, every day.
Okay. Once someone's diagnosed with a gynecological cancer, what types of treatment are available?
So, we focus on the three main treatments, three main ways to treat cancer. Those involve surgery, could involve chemotherapy or immunotherapy or other systemic therapies, and radiation. And with the variety of cancers that I see, there is a role for almost always one or two of those modalities. Endometrial cancer is actually the most common malignancy that we see, and that is mostly treated surgically. And the good thing about endometrial cancer is that most patients present with early stage disease, so we have a chance to cure them with surgery alone. As contrast to, say, maybe ovarian cancer, most of those patients present in advanced stage disease, stage 3 or 4. So those patients are lined up for a combination of aggressive surgery to remove all of the cancer and also systemic therapies with chemotherapy and sometimes immunotherapy. So it just kind of depends on the condition, the origin of site of the malignancy, and the stage at which the woman presents.
You've talked about a couple of different things, and hearing the word cancer is a scary enough thing. And then you talk about surgery. Can you talk a little bit about what types of surgery you perform in the treatment of gynecological cancers? And are there types that are more invasive or less invasive? And maybe give the listener a garden variety of what tools you have to help solve their problem.
Right. So the cornerstone of most GYN cancer surgery revolves around starting with a hysterectomy. That means taking out the uterus and the cervix, and oftentimes taking out the tubes and the ovaries as well. Now, certainly that's not the case for women that have vaginal cancers or vulvar cancers, but we're talking about cervix and up. So cervix, uterus, fallopian tubes, and ovaries. The first part of the surgery is usually a complete hysterectomy. And then beyond that, again, it depends on how advanced the disease is. Sometimes the surgery has to be performed radically, which means we have to take out not just the cervix, but the paracervical tissues, or the tissues around the cervix. And disease that is limited to its organ of origin, then we do what's called a staging procedure, where we take biopsies of certain areas in the abdomen and pelvis, focusing mostly on the lymph nodes that drain the organs of the pelvis. So that will give us what we call a staging surgery. And then other surgeries we refer to as tumor reductive surgeries or tumor debulking surgeries, where disease has already spread. And basically my mission is to get rid of all of the tumor deposits as much as possible, whether it means removing part of the stomach, the liver, the spleen, the intestines. Really, we have to go very big and get all of that cancer removed. And then there's two major ways we can do surgery. One is traditionally gold standard with an open incision. Most patients with ovarian cancer are going to have a large open incision with what we call a laparotomy. And then the other way to do it is minimally invasive with laparoscopy or camera surgery with small incisions, either done with standard laparoscopy or with robotic assistance.
Dr. Singh, tell us about your involvement in clinical trials and research for cancer surgery.
Well, being involved in research and clinical trials has been a passion of mine since I was a medical student. I've always been involved in research in some way or another. I am fortunate enough to be the lead, what we call PI or principal investigator, on a number of studies here, certainly the ones that we have for gynecologic cancers and a couple of other ones. I have the position of being in charge of what we call our protocol oncology committee, which is a committee that meets monthly, and we review how well we are doing with recruitment on existing trials, what are our barriers, and also presenting with the other cancer doctors new trials that are out there and assessing whether they are appropriate for us, meaning are we going to be able to enroll patients on them, and do we think that these trials offer a clinical benefit, meaning do we stand behind the science of those clinical trials. So that's basically my involvement. The way I was trained since I was a medical student is, we as doctors, it is our duty to advance the science without compromising offering patients standard of care. So for me, I always am thinking of a clinical trial for a patient. And to me, not enrolling on a clinical trial is an exception rather than it being the opposite way. So if we have a trial open that a patient meets criteria for, I'm always discussing that with her, explaining the benefits of going on a clinical trial, what it would mean, whether it's more involved therapy, and then coming to a decision together as to whether or not she wants to pursue it.
So, being that it is Gynecological Cancer Awareness Month, is there anything that women can do to prevent gynecological cancers?
The cornerstone for prevention of our cancers, just like any other cancers, is being aware of your body, paying attention to your symptoms, and presenting to a doctor early. Whether you think it's something normal or abnormal, even making something so simple as a phone call could prevent you from developing a cancer. I tell all my patients, I'd rather hear from you 100 times a day and tell you it's nothing than you deal with something that's potentially dangerous at home and not reach out and ask. So paying attention to your body, reaching out to your doctors, and advocating for yourself and your health.
All of these, techniques for checking your breasts and looking for lumps and all that sort of thing. How positive or is this? Okay, some women with very large breasts, they could have a tumor buried. Is that right? In the breast?
That's what's so great about mammograms is, so when you do a screening mammogram, and women should start getting their screening mammograms at the age of 40, they pull all of that tissue into the mammogram machine, or an overwhelming majority of that tissue. So that way, even with our very large breasted women, a good mammogram can see most of the breast tissue to help detect breast cancers.
So even clear up flesh to the chest.
Yep, they pull all that in when you get a mammogram.
Okay.
Sometimes our bigger breasted women, they do a couple different views because there's more tissue there. And so they want to make sure they get all that. So the mammotechs are fantastic of sort of making sure they get all that tissue in for a mammogram.
Now you said that when you were talking about various types of surgery and things like that. Does the cancer, and you were talking about the sheath, the skin over the breast, um, do lumps or various certain types of cancer, will they push through into the outer skin?
They can. So if a cancer is either small and close to the surface, it can go through the skin. Or if a cancer is larger and potentially neglected, I mean, those can also go through the skin.
And that would normally be ignoring a problem by the person, right?
Yeah, usually, unfortunately, yes. I mean, sometimes women see something and they're just a little scared to take that first step, and sort of they know something's wrong, but they're scared to know what it is, or they know what it is and they're scared for that diagnosis.
So is it common that they come to you that way or not?
We see a few women every year who present that way. It's certainly not the norm, but it's certainly not something that we don't see, unfortunately.
Yeah. Okay.
And so, I mean, just like Dr. Singh says, I mean, we sort of all tell women the same thing. You know, if you see something, again, we'd much rather see you and say, hey, let's look at this than to have something ignored.
Yeah. I just think of, as a pharmacist over the years, all the conditions that many people do ignore.
Yeah.
And I guess I'm wondering if there's a lot of ladies or women that do ignore the symptoms.
Yeah, unfortunately they do. And it's I mean, one of those things we always try to tell women, you know, please be aware of your symptoms, tell your doctor, tell someone that this is going on, and let us try to see what we can to treat it.
It is the bottom of the hour. Time for the news. Thanks for joining us this morning on Health Matters with the Medicine Center Pharmacy. Family Aultman Cancer Center. We have a lot more to cover this morning, so let's get back to the show. You both must be excited about opening the new Timken Family Center. I mean, it's absolutely beautiful. Looking down the street at it. Tell us about how this will change the way you provide cancer service to patients.
Dr. Singh, do you want to go first?
Sure. Yeah, sure. So our office right now is in the physician's office building, and the way up until today, all of our cancer services were set up is that we were just very scattered throughout different buildings in the hospital, different levels of floors, different physician office building here and there. So the first thing will be bringing all of the doctors under one roof, which naturally, I came from a couple cancer centers prior where that was the system. And the best thing about that is that it just naturally builds a sense of camaraderie and cooperation between all of the different types of doctors that are fighting against cancer. It also simplifies things for the patients, and that perhaps that's most important, that they know, you know, if I have to see my medical oncologist or my G1 oncologist or my breast surgeon, I kind of can just hop from one office to the other. Maybe that one doc could pop over and just make it easier for me. I can go downstairs, have my snacks, go to my infusion, get my blood works all done in the same place. And that's a huge deal. When you're navigating your battle against cancer, the last thing you want to do is be navigating a convoluted, scattered out hospital system. So, I mean, it's going to be amazing for us as providers, but more amazing for the patients that we take care of.
So what are we going to be doing in that cancer building? I mean, are you going to do radio? Tell me the works. Okay. I know that it's fabulous that everything is that you don't have to run from office to office, you know, that sort of thing. And that it's all right there in the building. And that certainly makes things more efficient. No, but go ahead. I'm sorry.
Radiation is right next door. And so it's all connected. So the ground floor of the hospital will be where all the infusion is, and that's where lab is as well. So patients can come in, they check in, they can have their blood samples drawn. The lab will run them right there. And then they can go upstairs to where the physician offices are. And so we have physician offices, we have nurse practitioners up there, nutrition, dietary. So there's all sorts of services that are then upstairs.
Sure.
And so it'll be great to have everything, just as Dr. Singh said, just right there under the same roof. And that way, everyone will be in that same area. And it'll be a lot easier for patients to go up and down, for physicians and providers to go up and down to help take care of patients that way.
So there are rooms for patients in that building. They're not over in the hospital.
Well, so they're infusion rooms. So for people who are going to get their chemotherapy or other treatments, they can have either a private room, a semi-private room, or we still have the shared communal spaces. Sometimes patients like having chemotherapy not by themselves, but sort of in a room with a few other people. And so we have a few pods of 4 chairs that are together, so that way people can sort of have support from, just other people going through sort of the same struggles and challenges that they are in the same pathways.
Tell me about any compared to what was being done or what you could do before with the hospital building. What new techniques can you do? Are there any with this facility? We've had many surgeons on our radio program over the years, and robotics seems to be the big, really one of the big movement of surgical types of surgery.
Yes.
Is that involved in what both of you doctors do?
So we don't do robotics in breast surgery. One of the things that we do instead of robotics, we do microsurgery, and that would be with our plastic surgeons. And so our microsurgeons can actually sew lymphatics. So one of the things that can happen is that when we take out lots of lymph nodes from women's armpit, they can get swelling of the hand and the arm called lymphedema. And so one of the things that we can do using microsurgery is we can actually sew some of the lymphatics that drain the arm into a small vein to help with drainage. And it actually reduces the rates of lymphedema by up to 50%, which is huge. And so that is one of the things that we can do. Now, there's no robotics in breast surgery, so I'll let Dr. Singh talk about robotics in gynec surgery.
Okay.
So robotic surgery is a technique that's been around, for a while. It's a different approach to minimally invasive surgery. So it's the same concept as using a small incision for a camera, insufflating the abdomen, and using smaller incisions that are basically 0.5 centimeter in size to introduce small instruments to perform a major surgery through smaller incisions. The benefits of robotic surgery in some specialties have very much been established. In GYN oncology, I would say that almost everybody that is coming out of fellowship now is trained in robotic surgery and minimally invasive surgery, and we really just choose based on advanced stage disease. Again, we're not going to want to do something with small incisions when our goal is to get every little thing out, but using minimally invasive techniques for patients that have organ limited disease is preferred. But we always kind of focus on the minimally invasive way is going to be better. But interestingly enough, we looked back in our specialty, looking specifically at patients that had radical surgery for cervical cancer. So those patients that were found in the first stage, and they compared patient outcomes with regards to those who had surgery from a standard open incision, whether versus patients that had surgery done with a standard laparoscopy or robotic assistance. And we actually found that when we were doing it minimally invasively, those patients were having more poor oncologic outcomes. So the standard has kind of shifted back. So we're always kind of exploring and pushing the edge and pushing the envelope forward to seeing what we can do minimally invasively. But we always have to kind of keep ourselves in check to make sure that just because we can do it, we also have to follow up and make sure that the long-term outcomes are appropriate and more favorable as well. So we offer all of our surgeries minimally invasively that should be done minimally invasively. But again, it's very individualized on who would benefit from that.
What you said, does this mean that the exploratory equipment, shall we say, can't really pick up all the issues in vaginal areas and stuff like that?
I think that's one part of it. But when you're working deep in the pelvis, in the spaces that we are working in, visualization is just as important as what we are feeling, because imagine when we're doing our pelvic examinations, what we're feeling for in a woman's pelvis, we're not able to see with our eyes. So we are so used to using our hands as a technique to examine and identify problems and examine cancers that it's not just all about the visualization. Certainly robotics does give you 3D view, but when you're not having that haptic feedback, it is limiting in that area. So again, there's a time and place for all of these minimally invasive techniques. And if we just keep ourselves in check and make sure that we're doing the right thing, then we can keep pushing with that. But also knowing that the standards are the standards for a reason.
It's interesting that the advancement in surgical techniques. Now, I had my gallbladder out years ago. Okay, I got this big cut. I don't know how many stitches, but now they're telling me couple pokey holes in the in that area, and you just pull that baby right out. Okay, so it is amazing some of the things that have occurred.
I think that's one of the great things about what Dr. Singh was saying is that, when you see someone like Dr. Singh and her level of expertise, she knows what's current and she's up to date on what is the best treatment modality, because just because you can do something doesn't mean you should. So that's one of the great things that we can offer. We have experts like Dr. Singh who will say, yeah, I can do it, but it's not the best thing for you.
Sure. Interesting. Go ahead, Brad. Sorry.
Okay, well, let's talk about best practices for screenings. So what kind of screenings do you recommend that women get on a regular basis?
So for breast cancer screening, we tell women a mammogram every year, starting at the age of 40. Until there's less than 10 years of life expectancy left. And so, and that's a conversation between either their primary care, the gynecologist, or if they're seeing a breast surgeon, of knowing when to stop. Now, the other group of women that we see are high-risk women. These are women with significant family histories, or sometimes just high-risk features even without a family history, and whether that's, their density of their breasts, or when they started having periods and menarche. And so all these things come into play. And a lot of times when you get your mammogram report will tell women, what is the lifetime risk of you developing a breast cancer? And if that lifetime risk is greater than 20%, we like to talk to women about what we call high-risk screening. And a high-risk screening is getting a mammogram every year, as well as a screening MRI. And that's to help detect cancers that are smaller or not detectable on mammogram, but also so that way they're getting imaging twice a year, because we know that those women are higher risk of developing breast cancer.
Time for a third break, I think, Brad. You are listening to Health Matters with the Medicine Center Pharmacy.
All right, let's talk about healthy lifestyle options for reducing risks.
Great, thank you. So I guess I always like to talk to women about just trying to eat good, healthy food. So fruit and vegetables, making sure you're exercising, limiting alcohol consumption. That's one of the big things we see with breast cancer. We tell women for having a lower breast cancer risk, you want to have a limit of 3 alcoholic drinks per week. Now, one of the jokes we have with that is you can have all 3 drinks at the same time, or you can spread that out over the week, but probably no more than 3 drinks per week. Trying to avoid the high glycemic foods, so your sugary sweet foods that are going to send your blood sugar up. It's all the good stuff. Unfortunately, it's the cookies, cakes, donuts, all the stuff that we like to eat. But limiting that, or trying to have a smaller portion after a meal, so it's not sending your blood sugar up as much. Good healthy foods, chickpeas, legumes, lentils, all those things that are good and healthy to eat. We like to think about a Mediterranean diet. So those are your seafoods, olives, just trying to, good healthy foods, and exercising as much as you can.
You read and hear a lot more now about genetic testing. Is there a place for genetic testing in your practices?
Absolutely. So we do genetic testing in all men who have breast cancer, or women who have a family history of men with breast cancer, women who have breast cancer at a young age, or women who have breast cancer with a family history, as well as certain types of breast cancers are sort of strongly encouraged to have genetic testing.
Well, what about cigarette smoking, alcohol, oral contraceptives, all in the same batch. This absolutely has to be a deadly trio. Is that correct?
So we try to sort of definitely discourage, excessive alcohol consumption, try to encourage smoking cessation. Oral contraceptives are an interesting thing because there's the hormones, which increase the risk. But I mean, as Dr. Singh can probably talk about, they also have somewhat of a protective effect for, if my understanding is correct, for ovarian cancer.
So, yeah, they have a protective effect for ovarian cancer and also for endometrial cancer. So ovarian cancer in somebody who's developing ovarian cancer sporadically or not due to a high-risk genetic family history happens due to, we call it the number of ovulation events, right? Every time a woman ovulates, she develops an egg, and there's a chance for something to go wrong in the DNA and for mistakes to happen. When you're on oral contraceptive pills or some other sort of hormonal therapy that prevents ovulation, that decreases the number of lifetime ovulation events and decreases the chance that you could develop ovarian cancer. For endometrial cancer, the protective effect from OCPs or other hormones comes from the progestin component. Endometrial cancer almost always is developed in a patient that has some sort of excess estrogen exposure, whether it's due to obesity, whether it's due to an imbalance of their hormones due to anovulation, whether it's due to an estrogen-producing tumor. The protective hormone against endometrial precancer and cancer is progestins, which is half of what's in an OCP. So it helps in two areas of patients that I take care of.
The oral contraceptives started out with a huge dose, clear back. I can't remember how far back it was, but they were 5 and 10 milligrams, one of the components. And over the years in the pharmacy, we heard an awful lot of excessive bleeding and stuff like that. So is it the low dose of these oral contraceptives that have kind of moved them to a better, what's the word I want to say here, safer?
Yeah, it's the decrease in the dose of the estrogen. Most women do not need a high dose estrogen containing oral contraceptive pill. In some patients, we do kind of escalate to a higher dose estrogen if we're using it more for menstrual cycle management, but most patients do very well on low dose estrogen containing therapies.
Well, I want to make sure that our listeners can get in touch with your resources that you have. I'm going to guess that often maybe you need a referral to talk to one of you, or can you talk about how patients can get more information from either you or about the Aultman Cancer Center?
Well, I guess at least for our practice, you can just call our office directly and say, hey, I'm worried I'm high risk. Will you see if I'm high risk? Or, hey, I just want someone else to talk to me about my cancer diagnosis. So our door is always open. You don't need a referral to come see us in the breast center.
So our system is a little bit different because we do have, the referral basis coming mostly from the primary care physicians and the OBGYNs that do a lot of the initial workup. So most of the time our patients do require referral. Certainly if you're calling for a second opinion, if you already have a diagnosis, that's going to be something that we can schedule for you. But most of the time for referral to a G1 oncologist, you are going to require a referral from somebody. Sometimes that referral can even be from, you went to the emergency room and they did an ultrasound and they found this abnormal finding. That's sufficient, but most of the groundwork, luckily, is done by the primary gynecologist and the PCPs before patients get to me.
Interesting.
Is there any final comments you'd like to share with the listeners to, be encouraging about taking care of their health or new information about your cancer center that you want to get out there?
Can I ask Dr. Singh a question?
Sure.
What are you guys recommending for screening for women? I hear so much. My patients tell me, oh, I don't need this anymore. I don't need a PAP. Or what are you guys recommending nowadays?
So the change in the Pap smear screening guidelines has been the biggest thing over the last 10 or 15 years, where our Pap tests are becoming more sophisticated, and we're not just doing the Pap test, which is looking under the slide, or looking under the microscope at a slide of the cells that are on the outside of the cervix. We're also doing co-testing with HPV. So as that technology becomes more advanced and specific, we're able to space out our intervals of Pap screenings from every 3 years in some women to every 5 years in others, but that doesn't take the place of having an annual pelvic examination. So that's the cornerstone, getting seen every year.
Yeah. Yeah, because sometimes patients come see me and they go, "Oh, I don't need to see them." And I was like, "I'm pretty sure they still need to check all your pieces, parts on the inside."
Yeah.
Gosh. Okay. All right. How are we doing for time, Brad?
we got like 2 minutes, so we can talk about anything. If you've got new technologies or new studies you're excited about,
Well, I think one
or
thing-
a good story that you're passionate about.
So one thing we didn't mention about our cancer center is actually we've carved out a huge area on the second floor, the top level, for a patient education and resource center, where patients are able to come in. They're able to get access to the internet if they don't have that. It's going to be it's kind of like a library feel. There's going to be some educational materials there. There's always going to be someone there to help you if you want more research about my condition, want more research about nutrition, or what are the services we offer here, or I want to sign up for some sort of insurance and I don't have internet at home. Can I use the computer? So that's something that we haven't had in any capacity here so far, even with us being scattered everywhere. So that's something new. We're hoping that the patients will take advantage of.
Very good. Very good. That's very interesting. Well, listen, thank you to our guest, Dr. Sabrina Shilad and Aultman Breast Cancer Surgery, Dr. Sareena Singh of Aultman Gynecological Oncology. We'd like to remind our listeners, if you suspect you have a medical issue, please contact your healthcare provider. Thanks to our sponsors, Aultman Health System, Studio Arts and Glass, and January Appraisals and Liquidations. As always, we thank our listeners for joining us on Health Matters with the Medicine Center Pharmacy. And we wish to thank you again, doctors. It's a very interesting program. Okay. And we're very, very happy to see Aultman with a new cancer center right behind us. Hopefully won't have to require any treatment there, but we hope that many, many people will get excellent care, and we know they will. So thank you again, doctors. We appreciate you taking time to come on Health Matters with the Medicine Center Pharmacy. Have a good day.
Thank you.
Thank you.